Hey folks, welcome back to the channel. I'm Drew. If it's your first time here, welcome. So in this channel, we are exploring functional anatomy, so how the body works, particularly in movement. And we're starting by investigating, exploring the muscular system. And today we're looking at the biceps brachii. Okay, so I always kind of think that the biceps groups is not very well labeled because bi meaning two. So we have bicep group. And here, bicep brachii, we have two heads, so that's where bicep comes from. But the actual biceps muscles themselves, like the group of bicep muscles, there are four of them. But we've already got quads in the legs, so we can't have two quad groups, so we've got biceps up here. Anyway, so we'll get into the other bicep muscles in another video, but today we're just looking at these two, the biceps brachii. And essentially, we have a common kind of insertion down near the elbow. And then very similar to the kind of gastrocnemius in soleus or triceps surae group, where you have a common tendon, and then you have at the other end, you have separate tendons and separate kind of muscle bellies, which is what we have here with the biceps brachii. So we have the lateral one. This is the bicep long head, and it's called a long head because the the tendon itself is got triceps in my head for some reason. The tendon itself is longer than this short head here. Okay, so this is the short head of the biceps brachii, and this is the long head, simply because you've got a long, kind of thin tube-like tendon, and then the short head has a shorter but thicker, bigger tendon down there. So if we look at our origin and insertion, so origin-wise, if we start with the biceps brachii short head, it's kind of come off this bone up here, this is the scapula, and this part of the scapula here is called the coracoid process. So your bicep muscle structurally attaches onto your shoulder blade, which is kind of like a bit of a head spin if you're not used to kind of understanding that. What that means is that anything you do with your biceps is going to affect your shoulder blade. Okay, so you can get really tight biceps, which basically will disrupt mechanics of the shoulder blade. And considering everything else that comes off the shoulder blade, off the scapula, it's a big deal. So we want to make sure we have good, functional, long and strong biceps brachii muscles. Now, the distal attachment for the short head is the common biceps brachii tendon down here, which goes onto the radius, which is your thumb side bone, onto what's called the radial tuberosity, which is this kind of extra bit of kind of bone here. Remember, we get a tuberosity typically as a point for the tendon to attach onto. You get more grip onto the bone, so you get these raised surfaces. The other big one, common one, is the tibial tuberosity, which is down here where the quads attach onto the tibia down there. Then if you look at the biceps brachii long head, the attachment of the long head is on this part of the glenoid fossa. So this green space here, this kind of concave space, kind of like circular groove, this is called the glenoid fossa. Okay. And so what happens is the head of the humerus here will sit snugly into this kind of groove, and then you get the rotation. Now it's a shallow groove, so it's not a deep socket like you have in the acetabulum where the femur goes into the pelvis. This is quite a shallow groove, and this is the kind of the plus and minus, the yin and yang of anatomy. So we have a shallow groove, but that means we get a lot more freedom of movement or range of movement, which then also means this has a lot of potential for instability. So if you get instability, that will require a lot more work from the surrounding structures to kind of create that stability. So everything is always a kind of like a trade-off or a plus or minus, not good or bad. It's just how it's kind of designed. And this part here is called the supraglenoid tubercle there. So the tendon is attaching onto the bone of the scapula just up here. And now the big issue with that, and we'll get into that, is that tendon sits just below the acromion process here and the acromion. And so the space between the tendon and the acromion process, if that gets compromised, you can get impingement. So a lot of kind of shoulder issues are really orientated around the impingement of this tendon. This is the one that often gets impinged in conjunction with this supraspinatus. So, and this space in here, they get jammed up, they get irritated, they get tendonitis, tendinopathies, tendon tears, and it's just a bit icky. I think I've currently got 4 clients I'm working with at the moment who've got various stages of tendon issues through here. And even though, like, one of my clients at the moment, he's got a ultrasound report, and it says that the tendon tear is 3 millimeters by 5 millimeters. So, you know, no longer than your fingernail in length, and maybe a quarter of that in width. But that's still, considering the actual size of the tendon, a big deal for the tendon. So that structurally weakens that tendon. So we need to kind of, rehab is all about facilitating the natural healing process and kind of like helping guide that along. So we're in that process of actually kind of getting on top of that with him. It's been a tricky one because mainly he plays a lot of golf, and golf is just this big rotational thing in the shoulder. And I kind of suspected he was getting a lot of impingement in golf. And then when we kind of asked him to have a bit of a break from golf after about 4 weeks of not playing golf, most of the symptoms kind of decreased on their own. So sometimes it's the thing we're doing that's creating the issue on top of an injury as well. So we have to look at the whole person, the whole picture. So that's our origin and insertion, or proximal distal attachment. So the next thing you want to look at there is innervation. So C5 and C6. So if we go back here, we have 6th cervical vertebrae, and then we have the 5th cervical vertebrae here. So C5 and C6. So the nerve root that comes out through here is going to go through underneath the traps and basically underneath the collarbone, and it's going to innervate into there. Maybe I can put it in motion. Oh, there we go. There's the branch. There we go. So here we go. That's so funny. I didn't mean to do that. It just happened. I just had to went to branches. So I take that back, 3D for Medical. You're an amazing program. I'm just the idiot who didn't know how to use it properly. So here you can see the nerves coming out of the neck. You've got multiple levels, so it's not just one level, but here's the primary nerve coming out of C5, C6, and coming down, as I said, between the collarbone and the ribs, and then threading into the different kind of muscles of the arm here, and you can see it kind of coming underneath. So if you get any kind of tightness through this region here, and this is what's often called thoracic outlet syndrome. So this brachial, it's called the brachial plexus, all these nerves coming out of the side of the neck. All right, so you get super tight scalenes, impingement, tight traps, you get a tight pec minor, tight Biceps Brachii short head. It all kind of compresses down and squishes the nerves, and so the signals coming to the muscles get interfered with, and we don't want that. So let's got to select the right thing. Okay, so let's have a look at some of the functional movements. Here we go. So here we have shoulder flexion. So one of the cool things with the Biceps Brachii is it's a 2-joint muscle, meaning that it crosses both the shoulder joint, glenohumeral joint, and the elbow. So it can have an effect on the shoulder and the elbow in isolation or together. So in this instance, the elbow is not moving, so the elbow is fixed, and we are doing elbows is an extension, and so then we got shoulder flexion. So if we look from the side, we want that. There we go, we got that one. So here we have in the orange, the Biceps Brachii muscle. So as the muscle contracts, it's going to pull on the elbow and it's going to lift your arm overhead. Now, look at the downward rotation of the shoulder blade as you're lifting your arm overhead. So this is the shoulder flexion. Okay, if we come from behind. So the whole angle of this shoulder blade needs to switch up to create that lift. Now, if you do have that really tight bicep brachii here, or a tight pec, or a tight pec minor, or a tight lat, okay, what's going to happen is as you lift up to this range here, essentially that part of the shoulder blade kind of gets pinned and it doesn't elevate properly and it doesn't kind of swing around properly. So then this part of the arm here is still trying to go up, and what's going to happen is it's going to connect into the acromion process here and get jammed up, and that's where you get those kind of tendon issues underneath through here. So when you're doing shoulder rehab, you must restore the full range of the shoulder blade. So you've got to address rhomboids, you've got to address lower trapezius, you've got to stretch out the lats, you've got to stretch out the upper traps, free them all up, so then retrain them so that the shoulder can move up. So because if this doesn't move here and you're still trying to reach up, you're going to jam your shoulder into the acromion process, and it's going to be not a fun time. The other compensatory thing will happen there is as this bone, the humerus, comes up and starts to contact into that and squish, to get more range of movement, what you'll do is you'll go into lumbar extension. So you'll do a back bend. So you'll lean back, okay, and that will then actually move your shoulder in a different angle. So this actual angle here won't change because you change the scapular position. It'll change because you change the lumbar spine position. And so that's how a lot of people who are trying to get into overhead position, so thinking you're doing a clean and press or a push press, military press, handstand, things like that, where you're trying to reach overhead. If you don't have the shoulder range of movement here, your body will compensate and give you, and by creating more extension in your lower back. So you'll lean back. So your arm will be here, for example, your stuff here, and so you'll lean back with your lower back to get that extension. Okay. So we want to be aware of that. A little bit of lumbar extension as you're reaching overhead is quite normal, but you don't want to rely on that and get excessive extension. So, and that's how people kind of injure their lumbar spine when they have really tight shoulders, because they're compensating for a tight shoulder with their lower back. And that's not cool. We don't want that. So that's the shoulder flexion. Let's have a look at forearm supination. Drink my lemon water. All right, so we're here looking at supination. So we're starting in the Anton position, so your thumb's out, palm forward, and that's the supination position. So the easy way to think about that is soup. So you're going to try to eat soup. So you're going to turn your palm up, and when you straighten your arm out, that means the palm's going to be forward. Okay, so thumb out. So follow the line of the contracting muscle. So as the muscle contracts, okay, now here's pronation. So that's in a shortened position there. Okay, and then as it contracts, it's going to pull and rotate a bone back out to turn the thumb out. So pronation, palm turns in, puts that muscle on stretch, and then as it contracts, it turns the palm out. Like so. So this is where you get, when you're doing a bicep curl, if you want to get the kind of the lower end of the biceps, what you want to do is start in pronation. So have your thumb turned in. So for example, so if you do a bicep curl, you're going to have your thumb turned in. And then as you curl up, you're going to turn your thumb out. Okay. So in pronation, thumb down, and then as you curl, thumb goes out. Okay. So other way, so here, or you can start in supination like this and then curl up. So you're going to be in supinated position. All right. But as you curl in, you supinate and rotate, and then you can bring that into a bicep curl there. So that's supination. And then let's look at elbow flexion. So elbow flexion, particularly in this example, is where there's no supination. So we're already in a supinated position, so palm forward. Okay. And then as the bicep brachii contracts, it's pulling on the radius, and then that's going to just bend the elbow up. Okay, so fairly straightforward, that one. Now, a couple of interesting things to note here is the elbow joint itself. Okay, here we have the alcanine process, which is tip of the elbow goes into the alcanine fossa here. So as we extend the arm, full range of movement will be whenever the bone of the elbow connects to the internal fossa of the humerus there to create that full range. So in this diagram, it's not really achieving full range. So you would say like that elbow angle there, if you dropped a line down there and you had a compass, that would be 180 degrees. Okay, so here we've still got probably 30 degrees of extension to go. So you're not in full extension. So if someone's got really tight biceps, what will happen is they won't be able to get their arm fully straight. Now that's either because they're really, really tight, or they might have a slightly unique elbow joint and the bone is connecting into the fossa earlier. It's just because of the structure of the bone and they literally can't straighten their elbow out. Okay, but typically what will happen is that most people should be able to get to a straight line, 90, 180 degrees in elbow extension, which means then you can use your triceps properly. All right, so tricep work is about getting this arm straight or into elbow extension. Okay, so this is something to be keep in mind. If you do too much bicep work and you don't work to full end range, or you don't stretch enough, or you don't do mobility work enough, you can get really tight in this region through here. And that will restrict not only elbow, which will then weaken your triceps, which will then weaken your shoulder extension mechanism, which will then typically make you use more upper trapezius to stabilize versus your posterior delt, your triceps, and your medial traps and rhomboids. So you want to make sure that you're getting this full range of movement through the elbow particularly. So you want that full elbow lock with control. Okay. So this muscle here is the brachioradialis. Okay. So this is another one of those 4 bicep muscles, and it goes down to the radius here and then comes up in the base of the humerus. So it's more of an elbow flexor, and it helps with that kind of turning of the palm down. Okay. So it kind of helps in that supination position. All right. Okay, so when you add those 3 movements together, so you got shoulder flexion, supination, and then elbow flexion. To do a proper bicep curl, you want all 3. So you want to curl the elbow, full elbow flexion, and you want to have that kind of go from turn from pronation thumb in, thumb out to get the supination component. And then you want to get the kind of the biceps activated by bringing into a bit of shoulder flexion. So you bring the arm forward a little bit in the curl. So you curl up, turn the thumb out and bring the elbow forward, and you'll get full bicep contraction there. Okay. And when you come down the other way, you want to go the other way. So you want to extend the elbow, turn the palm down, bring the hand behind you, and then extend all the way up behind. It's a bit hard to see in the video because the camera is chopping my arm off, but I'll do a proper video on that. And that's how you stretch the arm as well. So if you want to stretch the bicep brachii, you just simply reverse the actions. So you extend the elbow, you pronate the thumb, and you take your shoulder into extension, and you'll get a nice bicep stretch going on there. All right, so let me just put in a couple other muscles. Let's just show you them together. So other thing that I want to be aware of here is connective tissue. So we have here is the joint capsule, and the tendon of the long head actually kind of connects into and is wrapped around the joint capsule as well. So you can get capsular issues in this region pretty easily. So that's another thing we want to be aware of. We also want the supraspinatus. Just show me the muscle. Show me the muscle. Supraspinatus. Yep. And so now here we have supraspinatus, much bigger tendon versus the bicep tendon here. Okay, so a lot thicker. So typically you'll get in impingement supraspinatus and the bicep long head tendon getting jammed up. Sometimes it's one or the other. And they're so close to each other, it's often very difficult to kind of like discern without getting some imaging because you can't palpate it underneath the creming process, depending whereabouts it is. With your orthopedic tests, there's a lot of orthopedic tests you do where you basically put the muscle in a position where it's at its weakest position, then you test and you apply force to it and the muscle contracts when it's in its weakest position. So if there's any kind of injury or dysfunction, it usually creates pain. So we call that a provocation test, and that can give us a bit of an indicator that that might be the tissue that's involved. But there's so many structures here. It takes a lot of practice and skills to get good at orthopedic testing. And even then, if it's an acute injury, it can be really hard because there'll be a lot of swelling, a lot of pain, a lot of inflammation, a lot of guarding, and it can be very difficult to actually figure out what structure is involved. A good history is important, asking lots of questions. Where's the pain, quality of pain, what were you doing when it happened, all those things there, they help paint a picture. And then typically we tend to treat conservatively first, and then if we're not getting any results, depending on how people are presenting, we might refer off to get some imaging done just to, clarify what might be going on here because there's lots of different structures involved. Other one I just want to show quickly is pec minor. So pec minor here. This bad boy. Now, pec minor is important because it attaches onto the coracoid process here. So this part of the shoulder blade, the scapula. And you can just see from the angle, if you look down, how it's internal. And when it contracts, it's going to pull this shoulder down towards the ribs. So it's got this inferior pull. So if you get a tight chest pec minor and then a tight Biceps Brachii, those two create this kind of downward pull and it pins this shoulder blade basically to the ribs. And so that kind of creates that poor shoulder blade mechanism I was just talking about earlier. And so we'll do a full video on pecs when we get to the pecs after done the arm, I believe. So whenever we're working with shoulder impingement, tendonitis, tendinopathies, tendon tears, bursitis, they're all in the kind of like the broad kind of same bucket. And they're all going to present pretty much with inflammation, pain, and kind of spasming, guarding of pec minor, bicep short head, bicep long head, supraspinatus, and probably up here as well if we put in some scalenes. Let's get left side scalenes. Kapow. Now, these scalene muscles are sitting just behind this brachial plexus, this C5, C6 nerve, which comes out into the Biceps Brachii. So if you get really tight neck muscles, you can kind of compress these nerves coming out through here, and you can kind of get kind of neurological signs like numbness and tingling and pain, which travel down the arm. And so we need to basically address the neck at this level here as well. So we're not getting any, we're allowing the nerve coming out of the neck underneath the collarbone between the rib and the axilla to be able to slide and glide and mobilize freely. So there's no interruption to the communication of the nerve at all. So if we don't address that kind of scalene, which is usually the big problem muscle, and it also attaches on the first rib, so it's going to elevate the first rib up as well, and that's going to then compress the first rib in between the collarbone through here. So it's going to pull this rib up, and then that can create more jamming as well. So it can get quite complex, but essentially what we need to do, we need to address all these. These are the problem muscles. So these are the ones that are going to be really tight and kind of drawn and hypertonic and restrictive and tense and adhesed. We need to release all those with myofascial release, pre-nerve stretching, myofascial techniques, massage therapy, dry needling, acupuncture, whatever tool or method we need to get into these tissues to stretch and release them. Then we need to strengthen all the posterior muscles, so rhomboids, middle traps, lower traps, triceps, cervical extensors. And then we need to kind of retrain that whole pattern, which is the tricky part of the shoulder, because we've still got about 18 muscles here we need to address to get a properly working shoulder. So it's quite complex to wrap your head around, but that's where I would start with. If you're new to working with shoulders, okay, biceps, stretch and release, pec minor, stretch and release, scalenes, stretch and release, supraspinatus, stretch and release. Okay, start with that first. So you're doing your manual therapy or your myofascial release. Then in terms of exercise, you're doing the opposite here. So infraspinatus, subscapularis, we want tricep group, rhomboids, middle trap, lower trap, cervical extensors, all strengthened. Just because what will happen is this whole shoulder mechanism will be pulled forward, internally rotated and depressed down. And so we want to be able to pull the shoulder blade back and start to develop that postural kind of mechanism. So that's the kind of the bicep brachii. It's a super important muscle. Okay, crosses the elbow, crosses the shoulder. Okay, often it's not the bicep that's the problem, it's the neck, it's the chest, it's a weak upper back, and the bicep is just taking a lot of the load, a lot of the work, and then this tissue gets irritated and grumpy and it doesn't like it. So I hope you enjoyed that video. If you did, leave me a like, a comment, and a share. They're all appreciated. YouTube at the moment loves comments. So if you do have any questions, please drop them in the comments. I'm always happy to answer questions where I can. In the next video, we're going to be looking at the bicep brachii. Let me put it in. There we go. So this is a big muscle, big bicep muscle, which kind of sits under your tricep, your bicep brachii here. And this is the big, powerful elbow flexor. This is the preacher curl muscle. So we'll look at that one in our next video. So hope you're having a great day. Keep studying, keep learning, keep practicing, stay healthy, and we'll see you in the next video.